You know, at the starting of my presentation, I asked that my supervisor asked me कि अगर एक पैथोलॉजी बच्चे में है तो आप दूसरा भी ढूंढें. तो we have to ask pediatrician for systemic evaluation. कभी कभी हम लिख भी लेते हैं, आप जो कह रही हैं वो हम एडवाइस भी करते हैं, pediatrician कहते हैं कि नहीं इसकी कोई ज़रूरत नहीं है. So for anesthesia and all the systemic evaluation, we ask them to do for fitness for general anesthesia and systemic evaluation कि PDT वगैरह तो नहीं है और विल्मर चिसानी मैडम का कह रही है होमोसिस्टिनुरिया तो नहीं है, तो वो डाउन सिंड्रोम
में एक सेकंड क्या इंपॉर्टेंट सिस्टमिक इन्वेस्टिगेशन करनी चाहिए डाउन सिंड्रोम में इको, ठीक है ना, कि उसमें हार्ट प्रॉब्लम्स होते हैं, अगर आप प्रैक्टिकली कैटरेक्ट्स कर रहे हो तो इम्पोर्टेंट. दूसरी इम्पोर्टेंट बात, Dr. Nazli pointed a very important point about the posterior lenticonus and posterior polar cataract. What important thing as a precaution and as a complication can occur in the surgery in these patients? Advance? इसी रेंट हो सकता है, तो क्या खास टेक्निक करते हैं आप जिसमें ये इजी हो जाती है सर्जरी? एक और
presentation.
आपका बच्चा तो शैतान लगता है.
Bismillahirrahmanirrahim. Respected Professor Ziaul Islam, I'm happy that I'm talking in front of him. I was his house officer, and then I was registrar with him. And whatever development you see in the Khyber Teaching Hospital, it was because of Professor Ziaul Islam. Professor Sanawala Jan, I'm really grateful and I'm privileged that you have invited me to be part of this pediatric ophthalmology workshop. Respected doctor from Islamabad, colleagues, students, ladies and gentlemen. My topic, the second request is, my topic is full of controversies and disputes. So I will request Professor Sadia.
I will not ask. At the end, now I'm
we
writing
can,
down
yes,
in the notes.
we can discuss it at the end, right?
I honor the suggestion of Sanawala Jan.
Pediatric cataract is a very important cause of childhood blindness, and it is remember, it is a preventable cause of childhood blindness. So the burden of this childhood blindness is around 200,000 around the world, and the prevalence is it is different from different studies. So it is the estimation is 3 to 6 per 10,000 live births.
The burden 200,000.
Blind due to congenital cataract.
But prevalence, if it is 3 to 6 per 10,000 of this, is 200,000 not very small figure?
These are blind, not congenital cataract. Blind due to congenital.
They are blind.
After treatment.
After treatment, treatment and then.
Yes. So the aim of surgery of cataract, pediatric cataract surgery is to restore a clear visual axis, to enable the retina to see things clearly and prevent amblyopia. So the other aim of our surgery is, after doing cataract surgery, we have to visually rehabilitate these patients, because if you operate on these patients and you leave it as such, so our purpose is not solved. So we have to really visually rehabilitate these patients in the form of glasses or contact lenses, or if you think you can implant the intraocular lens. And to ensure appropriate investigation for the cause of the cataract, as it was said by Dr. Nazli, that we have to investigate these patients to ensure what is the cause of the cataract, and we could be prevent it in subsequent patient, and to ensure safe and general anesthesia. So pediatric cataract surgery is really not only unique, but it's also very challenging. So, as pediatric specialist or pediatric ophthalmologist, you all know that it's very frustrating to examine a child, and you have to, you cannot reach your diagnosis in a single examination. You have to repeat it probably several times under anesthesia to reach proper diagnosis. Then after diagnosis, you have to decide about the surgery, and for that you need to know the size, the location, the laterality of the cataract, and then everything from diagnosis until surgery and post-operative care, everything is different from adult cataract. So when you see an adult cataract, a white cataract, so you feel tempted that I should do this cataract because you are almost 100% sure that there'll be a very good visual outcome and the patient will be happy and I will be happy. But when you see a pediatric patient with congenital cataract, so you are very apprehended and you feel sort of a lot of worries what will happen in future. So and remember, removal of cataract is only the first step. So there is a long and wavy and thorny road ahead. So you have to follow these patients. You have to visually rehabilitate these patients, and you have to look after for the amblyopia doesn't develop, and you have to prevent or treat the posterior capsule opacification, because if you don't do it, so your surgery would be not that much effective. So the pre-operative assessment that my job was made easy by Professor Dr. Nazli. So our patients, they are in such an age that they can't talk. They can't tell you what's wrong with them. So in pre-verbal children, you have to decide, you have to examine the patient, and you have to decide about the surgery. My professor, my supervisor's son was veterinary eye specialist. And once, they were sitting and both of them were talking about the specialties. So the son said that, Dad, my patients are very special because they can't talk. So my supervisor told him that, my patients can't talk either. So our patients, we have to, we have a lot of, we need to do a lot of efforts to examine these patients thoroughly and to ascertain what sort of cataract it is and does it need any interference at all. So the presence of strabismus, especially in unilateral cataract, and the presence of nystagmus and poor fixation in bilateral cataracts, it warrants you, or it warns you that it has become an emergency, so you have to operate them as soon as possible. You have to quantify the visual acuity. So a number of tools are available, which was stated by Dr. Nazdi. So you can measure the visual acuity, and you can predict which patient will have good vision post-operatively or not. And of course, you have to examine the anterior segment to exclude any abnormalities of the anterior segment, which will affect the future visual potential. You have to know the quality of the red reflex by examining the patient. So that will tell you a lot about the morphology of the cataract and the actual site of the opacity, and a lot more about the congenital cataract. So the size, the density, and location of the opacities must be noted, and every opacity does not need removal. intraocular pressure measurement is very important to exclude glaucoma because certain cataracts, they are associated with increased intraocular pressure, especially if the eye is microphthalmic. Fundus examination, again, very important to see any pathology at the back of the fundus and, to make the parents inform about it. So that because, they have a lot of expectation. So if there is something wrong at the fundus, if there is maldevelopment or underdevelopment of the macula or disc, so the visual potential is much less. And in case of dense cataracts, when there is, the complete cataract, white cataract, you need to go for B scan to assess any information regarding the back of the eye. So before going for surgical intervention, you have to assess what is the impact of the opacity on the visual function. So small opacities, peripheral opacities, or central opacities which are less than 3 millimeter diameter, so they don't need removal. And remember that, phakic vision is much, much superior as compared to aphakic or pseudophakic vision. Sometimes if the opacity is central and small opacity less than 3 millimeter diameter, so you can use the dilating drops, and the baby is able to see through the clear peripheral lens. Also, these patients are usually having refractive errors. So you need to refract them, you need to give them proper glasses to prevent amblyopia. Sometimes you can take input from the school teacher because, these patients, they go from one doctor to another doctor. And आपके पास आ जाता है, आप कहते हैं कि जी सर्जरी कर लो, दूसरे के पास चले जाते हो, कहते हैं कि जी अभी ना करो. So sometimes when this sort of situation comes to me, I just tell the father, go to the school and ask the school teacher, how is he going around in the school? Is he progressing? Is he complaining of anything? Or is it at par with the other student? So if there is any problem, they come back and say that, well, it's the baby is normally growing and everything is okay. No, man. Right. So. Right. So, decision about surgery, it's a very controversial topic. So, at what age, what time should we go for the surgery? So, there are, a lot of problems in pediatric cataract. On one side, there is, the risks of general anesthesia. These patients are obviously, when they are having cataract, so they are when small babies, they are very fragile and very difficult to handle them. And there is a risk of glaucoma, which is again a blinding disease, right? And then there is the risk of deprivation amblyopia. So you have to keep each and everything in mind, and you have to keep a balance. You always talk of a critical window within the sensitive period. So there is a sensitive period and there is a critical period, right? But nobody knows at what time this critical or sensitive period starts and at what time it ends. But the usual consensus is that you need to operate these patients on at the age of in unilateral cataract at the age of 4 to 6 weeks. Right, and in case of bilateral cataracts, you need to operate them on 6 to 8 weeks. But you can safely postpone the surgery until the baby is fit enough, up to 10 or 12 weeks. I usually operate after 2 months, because the risks of anesthesia, the state of the baby health, and all these things should be kept in mind. The decision of surgery should be communicated to the parents, because the parents, and again, the parents should be mentally and physically fit to handle these patients later on, because you need to follow these patients throughout their life. So you have to discuss it with the parents, and you have to you have to warn them about the rigors of amblyopia and aphakic glaucoma and posterior capsule opacification. So, for all these things, they have to bring the patient for follow-up and for management. Surgery need to be performed by surgeons with reasonable experience. Cataract surgeons may be extremely, general cataract surgeon may be extremely competent, but pediatric cataract surgery, as we discussed in the beginning, it is different from adult surgery. So the surgeon may be extremely competent, but he may not get enough time to follow these patients and to look for the complications later on. There should be adequate facilities of anesthesia, and that's why the patients are usually referred to these tertiary care hospitals, because the anesthesia facility, especially the pediatric anesthesia, is usually not available at the district level. Again, another controversial issue, whether you want to do bilateral cataract in one sitting or cataract in different sitting. So usually, personally, my experience is that I do cataract, congenital cataract. If it is bilateral, I do it in one sitting. But if I plan to implant an IOL, then I do one eye at a time. Never do both eyes together when you are planning for intraocular lens implantation.
Is the age factor to this decision? At any age, if you are implanting bilateral, you don't go for bilateral.
Don't go for because simple extraction is little bit easier, and there are the prediction is there are not much complication. But when you are implanting the IOL, you have to do anterior vitrectomy, you have to do posterior capsulotomy, and then there is
Vitrectomy, posterior capsulotomy, probably. I don't know. I'm not pediatric, but probably you have to do it in all cases. Is it not like that?
Well, depends on the age of the patient. For example, a patient presents to you at the age of 4 years. So, and you think that this patient will be fit, say after 24 months, he will be able to cooperate by if you do YAG laser, right? So you can you don't do posterior capsulotomy or anterior vitrectomy. So these patients usually they do well with laser.
Professor, there one query. Do you have any cutoff line for implanting IOL?
No, but I personally, I am not in favor of implanting IOL below 2 years of age. And I have seen, because I have so much, I'm in pediatric ophthalmology since 1998, so I have seen the complications, and I'm reluctant to do intraocular lens implant below 2 years of age.
Till then they are aphakic, and then secondary implant?
Yes, that's a very good procedure. ये जो आप मतलब पहले उसको कैटरेक्ट रिमूव कर लेते हैं, और जो भी इन्फ्लेमेशन है, जो भी मतलब मेम्ब्रेन, वो सब कुछ हो तो आई भुगत जाती है ना, तो दोबारा जब आप करते हैं तो उसमें ज़्यादा इन्फ्लेमेशन और ये चीज़ नहीं होती. So I go for secondary lens implantation afterward, right?
And with exception of unilateral cataract.
With the exception of?
If you say dense unilateral cataract,
J.
then because that's where the controversy starts.
That's right. If it is a unilateral cataract, then again personally I am reluctant, because when the patient presents to you, so already the sensitive period and the critical period has passed, right?
Whoever has developed has developed.
Yes. So,
Myopia-wise.
तो one should not do it just for the sake of doing it. बाद लोग कहते हैं ना कि जी मैं तो 6 महीने के बच्चों में भी लेंस डाल देता हूँ. एक हमारा वो था लाहौर में, उससे मैंने पूछा कि यार वो तो कहते हैं कि जी मैं तो सर उसमें 6 months में भी डाल देता हूँ. तो मैंने उससे पूछा कि यार आपने फिर उसको देखा भी है? तो कहते हैं यार मैंने देखा, वो तो मेरी तरफ देख रहा था. दिस इज आई मीन
सर लेकिन उसमें इनहाउस ऑपरेटिव भी एक रिस्क होता है ना कि यूनिलेटरल कैटरेक्ट है उसमें एक में तो ठीक उसका कोई एरर नहीं होगा, दूसरी साइड पे यू विल हैव अ हाई क्लासेस ऑन दैट नंबर ऑन दैट साइड, तो वो टॉलरेंस इक्वेशन की इट्स अ प्रॉब्लम कि वो एक साइड पे
Then probably contact lens would be.
देखिए
ये यूनिलेटरल
कॉन्टैक्ट लेंस प्रेफर्ड
ये यूनिलेटरल कैटरेक्ट वाली जो बात है ना, इट्स टू मच कंट्रोवर्शियल. और आपको अगर याद हो, बहुत पहले हमारे बुक में होता था कि द यूनिलेटरल एफेक्टिया इज मच गुड स्टिमुलस फॉर एंजाइटी इज यूनिलेटरल कैटरेक्ट. तो इसको अभी छोड़ दें. बायलेटरल कैटरेक्ट की जो है बच्चों में सर्कुलर को ठीक है रहे हैं. एज इसकी जो है रिकमेंडेड एज, इवन एमसीक्यू आ सकता है, पहले 4 साल था, फिर 3 साल हो गया, प्रेजेंटली इट इज़ 2 years. तो आई विल के लिए जो है एज इज रिकमेंडेड. ठीक है, पर्सनल वो है, एक्सपीरियंस सर्जन है, वो 1.5 साल में भी कर लेंगे, 1 साल में भी कर लेंगे. पर फॉर ट्रेनिंग्स इट्स 2 years के आप आई विल लगाएं. और पोस्टीरियर कैप्सुलाटमी टेक्टमी, सर की बात ठीक है. अगर आपको लगता है बच्चा बहुत ऑपरेटिव है, सिर्फ पे बैठ सकेगा फॉर कैप्सुलाटमी, तो 4 साल में भी, लेकिन रिकमेंडेड एज इज 5 years. कि 5 years तक आप पोस्टीरियर कैप्सुलाटमी टेक्टमी करें. उसके बाद मतलब एक के ना
For-
आई विल इज 2 years प्राइमरी आई विल इम्प्लांटेशन.
यार ये पंखा तो सर चलवा दे. चाहते हैं
आप
तो
pediatric ophthalmologist बैठे हैं. Can I ask one question? That if you implant the IOL in a child of 2 or 3 years, what about later on? Do you replace it or will it just continue as such?
सर इट्स अंडर करेक्टेड
30% correction करते हैं.
उसमें
ये अभी
2 years का जो है वो कहते हैं कि सफिशिएंटली आई बाय द एज. ये 2 साल का रखा है इसलिए है कि एनाटॉमिकली प्लस रिफ्रैक्टिवली वो जो है रिफ्रैक्शन वाइज काफ़ी ग्रोथ उसकी कार्नियल डायमीटर जो है वो इफेक्टिवली रीच हो गई होती है. रिफ्रैक्शन का उसमें थोड़ा रहता है, तो इसलिए उसको वो अंडर करेक्ट रखते हैं आई विल को. सो आई रिमेंबर करेक्टली, तो 2 साल में अगर करते हैं तो इज इट 30%, 20% अंडर करेक्शन करते हैं. 3 years to फिर
2 to 8 years is 10%.
हाँ, 5 years तक यूजुअली कुछ लोग फिर उस पर जो बायोमेट्री होती है उसी पे करते हैं, लेकिन 5 years से कम जो होते हैं अंडर करेक्ट करते हैं. और वो उसकी जो है कॉर्नर के लिए क्लासेस देते हैं जब तक कि वो रिफ्रैक्शन उसकी ना हो जाए.
इसमें एक चीज मैं जरा ऐड करूं कि जो उसमें आई विल है इसमें स्टेबली हिस्ट्री जरूर है
These controversies are coming.
so
मैं तो नहीं बोल रही ना
for quite yes
सलाउल्लाह की बात में मैं चली हूँ.
for quite some time I was not doing unilateral cataract at all. और इसके ऊपर मैंने काफ़ी पेपर पढ़े थे, काफ़ी वो. अब भी अगर टोटल कैटरेक्ट नहीं है, पेरिफेरी क्लियर है, थोड़ा सा मतलब स्पेस है बिटवीन द लेंस फाइबर्स, so I'm reluctant because if you do these patients, so doing and not doing is equal. The patient is already amblyopic, so why to subject the patient to
यूनिलेटरल कैटरेक्ट का हम कांटेक्ट लेंस एंड एम्ब्लियोपिया थेरेपी देते हैं, मतलब वो बिल्कुल विजुअल एवरी 12 और 6 तक बिल्कुल पहुंच जाती है. लेकिन यही आपकी बात है कि फिर वो रेगुलर जो है पेशेंट थेरेपी और कांटेक्ट लेंस पेडियाट्रिक कांटेक्ट लेंस होते हैं, लेकिन बिल्कुल इम्प्रूव है. वहाँ इवन जो मेलबोर्न में हम करते हैं वो कहते हैं कि बिल्कुल क्या करें, और कांटेक्ट लेंस एंड एम्ब्लियोपिया थेरेपी विजन बहुत बेहतर होती है. अच्छा, एक दूसरी चीज जो आपने उसका बताया ये 1 सेशन में, तो उधर हमें ये बता दें कि आप उसके लिए कि बहुत 1 सेशन में करना चाहते हो तो उसमें आप अपनी होटी के एंडोफ्थल्माइटिस रेट को आप भी कंसीडर करेंगे कि अगर एंडोफ्थल्माइटिस रेट्स आपकी ज्यादा नेवर गो फॉर बोथ आइज इन द
नहीं, वो तो ठीक है. दूसरी बात ये है कि you have to be very careful. So if the operation is doing in the same setting, so you have to use separate operation trolley for each eye. Even you have to change the towel, right? So you have to be very, very careful. And the proponent of bilateral cataract surgery say that if you delay the operation by months, so there is chances of developing amblyopia. So the gap should not be more than 1 week.
Just 1 week.
The gap should not.
It's my experience. I have initially done a patient जिसका एक eye में मैंने क्या किया after 1 week मैंने दूसरी eye plan की और इसका squint develop हो गया. So now I am doing both eyes simultaneously. And thank God कि मुझे bilateral में करनी second appendix नहीं हुआ.
ये उसका वेट न करें कि जो आप कह रहे थे because it is very such a disaster and such कि आप सारी जिंदगी उसको बच्चा आपको दोनों आंखों के साथ and I am telling this because it has happened to me.
It happened once in
ये एक दफा हो जाए आप
once in Literating
इसलिए
hospital.
कहता हूँ इसका वेट न करें कि आप हो जाए प्लीज.
लेकिन I changed the gloves set everything right
ये तो आप एक हफ्ते की नाजली एक हफ्ते की आप बात कर रहे हैं ना, वो पेशेंट इतना प्रोन होता है टू डेवलप एम्ब्लायोपिया कि एक दिन में भी डेवलप हो जाए. अगर आप उसको पैच कर लें तो जाहिर है 2-3 दिन तो पैच रहता ही है, तो उसमें भी डेवलप हो सकता है. सो दैट्स व्हाई इट्स
और एक और इम्पोर्टेंट फैक्टर यूनिलेटरल या बायलेटरल में और एटलीस्ट फॉर मी कि सेहत कार्ड एक को अलाउ करते हैं कि 2 को अलाउ कर दो.
right. So I repeatedly say that the pediatric cataract is totally different to adult cataract, and that is because the smaller size of the eye in pediatric age group, the change in the axial length with time. The baby has an axial length of 16.5 millimeter at birth, and this there is a rapid increase in the first 18 months of age. So almost 80% of the eye has gained the original axial length, but the adult length is achieved at the age of probably 13 or 14 years. So the normal axial length of 23 millimeter that is reached by teen age. Then there is a change in the corneal curvature with time. So at birth the corneal curvature is 51.2 diopter, while at the age of 13 years it comes down to 43.5. There is increased tissue reactivity, and that is very discouraging. The patient, the baby's tissues, they are very reactive. Sometimes you see membrane forming on the table. For example, you have washed the lens, you come to the instrument trolley, you want to pick up something, and you go back, and a membrane is formed on the pupil. So I have been very uneasy with this. Then I talked to my supervisor in Australia, and he now for so many years I am using heparin injection in the drip. So 1 unit per ml. So if you do that, so there is no membrane formation, and next morning you get a very round pupil, no synechiae, no inflammation, very minimal inflammation. And there is a decreased scleral rigidity and increased vitreous upthrust. So when you remove the cataract, the vitreous just comes up. So for this you need to have a separate cannula, the irrigation cannula in the anterior chambers to keep the anterior chamber formed. And that is helpful in other things as well, that when you are removing the instrument from the anterior chamber, so there is less pressure on the vitreous and there are less chances of rupture of the hyaloid membrane. The anterior capsule is very, very elastic, and that's why it's very difficult to do CCC in small children. So you must have noticed that, if you can see the anterior capsule, there is no need to inject the trypan blue. But I do it because when you inject this vision blue, the capsule becomes tightened, and then your CCC becomes a bit easy. So you just try it, right? And the pediatric cataract is different to adult cataract because the lifespan after cataract removal is maybe that this baby lives for another 60 years. So if your operation is proper, if everything is okay, if you are treated, given him or visually rehabilitated him or her, and everything is okay, then otherwise the patient is going to be blind for the rest of the life. And also, the parents are attaching a lot of hopes with these babies. So surgical techniques has been evolving, and especially after the a lot of instruments have been developed, technology is developing. So there is a constant evolution in the pediatric cataract surgery. You have to have a customized approach for each and every patient, depending on the size, the location of the opacity, the age of the child, the laterality, and the morphology of the cataract. So, a number of different options are available. So, depending on the surgeon's preference and the age and morphology of the cataract. Then the biometry, again, it's a separate topic, what type of biometry or, what formula are you using. But, just before operation, patient under general anesthesia, you can have the biometry, you can estimate the power of the IOL. And the wound construction, again, it is totally different from adult. The small tunnel wound or whatever wound is, you have to stitch it, right? Because if you don't stitch it, there is likelihood that it will leak. And again, I personally applied 2 sutures, because if you apply 1 suture, sometimes what happens, there is a fish mouthing. And next morning, and this is a very, very potential cause of pupil blood glaucoma, right? And it's advisable to do peripheral iridectomy as well in pediatric cataract. So that is, a sort of deterrence to develop the angle closure of this pupil blood glaucoma. And you have to, if you don't apply a second suture, it is very difficult and inconvenient if you do the same thing again next morning, which is inconvenient to you as well as to the patient. So again, we have discussed that anterior capsulotomy is very difficult and challenging. Sometimes, you can use the phaco probe, but the lens matter is so soft, unless it is something like membranous cataract or some hard material there. So you should not use phaco, because it can easily come out with the irrigation aspiration cannula. Then the management of the posterior capsule. So if you are planning to implant the lens, so you have to do posterior capsule, cutting off the posterior capsule, and then if you want to implant the lens and you do the capture, the posterior capsular capture of the IOL, then it is, and you have to do anterior vitrectomy as well. Because if you do only posterior capsulotomy, the anterior vitreous face becomes opacified. So the sir has asked this thing, power of IOL. So what we do that in patients, we keep the patients, for example, the biometry is say 28 diopter. So we correct them 20% less than whatever the biometry is. In case of patients who are below 2 years of age. Over 2 years of age, then we undercorrect them by 10%. And there is no undercorrection if the patient is above 8 years. So the surgery, again, don't take it as, the general surgeons, they are very good surgeons and very competent surgeons. But pediatric cataract needs special attention and special consideration because you people are very busy, you are not able to follow these patients for complication. So it should be done with very uh, for, by surgeons who have got reasonable experience in dealing pediatric cataract and pediatric who have seen the long-term complications of these cases. The sutures we have discussed, all wounds, including the side port, they should be stitched in pediatric cataract, because if you leave it open, the cornea and the sclera, it is so elastic that it will leak and it will cause shallow anterior chamber and its related complication. So as I mentioned, the heparin in the irrigation fluid at the rate of 1 unit per ml will keep the inflammation and prevent the formation of the fibrinous membrane. And use of triamcinolone if you are doing vitrectomy, so it will stain the vitreous, and the trifon blue, that staining of the anterior capsule, that in addition to staining, it causes stiffening of the anterior capsule, and the CCC becomes little bit easier. So visual rehabilitation is very important and must be done as soon as possible after surgery, so that the patient get a clear image and develop vision in both the eyes, equal vision in both the eyes. So you can prescribe spectacles in the first week, and then you can go for contact lenses by an expert after 2 or 3 weeks. But again, as I told you, for contact lenses, you need to have educated and committed parents. Evaluation of the visual acuity, repeated evaluation of the visual acuity when the patient comes to you to see for amblyopia developing, right? These patients, and you have to warn the parents that, you know, if we have done the cataract surgery and the patient is going to be, you know, having some vision, but these patients are prone to develop strabismus if the vision in one eye is not developed and the patient has developed amblyopia. So they will need further interference and further surgeries. So regular follow-up of these patient is needed to watch the aphakic glaucoma. I have a study on aphakic glaucoma, which was a 14-year study which we did in Mardan Medical Complex, that is from 2000 to 2014. And you know, some patient presented to us 5 years after cataract surgery. So this should be in your mind that aphakic glaucoma, open angle glaucoma, can develop any time after cataract extraction. So we need a dedicated team which includes the parents as well. So in conclusion, pre-operative assessment is essential to determine the appropriate timing of surgery for proper vision development. The decision to remove unilateral or partial cataract can be difficult and challenging in infants and children. So you have to discuss it. You have to discuss it with the parents. Even you can discuss it with your fellow pediatric ophthalmologists. Because phakic vision is much better as compared to aphakic and pseudophakic vision, the phenomena of refractive growth and the process of immaterialization have continued to puzzle pediatric ophthalmologists. So very, very challenging field again. Vision loss from posterior capsular opacification, large refractive shift that is developing of myopia after cataract surgery, amblyopia and secondary glaucoma are still major post-operative complications which should be looked after throughout the life of the child. Thank you very much.